Myasthenia gravis is an autoimmune disease of the neuromuscular junction. In this condition, the immune system mistakenly attacks acetylcholine receptors at the neuromuscular junction. This disruption prevents proper nerve signals from reaching the muscles, making them weak. The thymus gland, which helps regulate the immune response, may play a role in myasthenia gravis by incorrectly instructing immune cells, leading to the production of these harmful antibodies. In some cases, the thymus can become enlarged or develop tumors.
According to the Cleveland Clinic, myasthenia gravis or MG manifests in several forms, each with distinct causes and characteristics. The first form is the autoimmune myasthenia gravis. It is the most common form of MG, driven by the immune system erroneously attacking the body's own tissues. The immune response generates antibodies that obstruct nerve muscle communication, particularly targeting proteins at the neuromuscular junction, such as muscle specific kinase or acetylcholine receptors. Autoimmune myasthenia gravis is classified into two primary subtypes. The first subtype is the ocular myasthenia gravis. It affects the muscles controlling eye and eyelid movement, leading to symptoms like ptosis or dropping eyelids and diplopia or double vision. Ocular MG can advance to generalized MG in about 50% of the cases. Generalized myasthenia gravis. This subtype involves weakness across various muscle groups beyond the eyes, impacting facial, neck, arm and leg muscles as well as those required for speaking, swallowing, and chewing. The second form is the neonatal myasthenia gravis. This form occurs when a fetus inherits antibodies from a mother with MG. Symptoms in the newborn include weak crying, poor sucking reflexes, and generalized muscle weakness. Neonatal myasthenia gravis typically resolves as the maternal antibodies dissipate over a few weeks to a month after birth. The last form is the congenital myasthenic syndromes or CMS. Unlike the autoimmune myasthenia gravis, CMS arises from genetic mutations affecting neuromuscular transmission proteins. This hereditary condition usually presents early in life, often during infancy or childhood, and symptoms include muscle weakness and potential breathing difficulties. CMS is treated differently due to its genetic basis.
So now, let's proceed on the clinical signs, symptoms, and diagnostic approaches that are critical for recognizing and understanding MG in a clinical setting. So these are the types and diagnosis. First is the ptosis or the dropping of eyelids. One of the earliest and most frequent signs of MG, ptosis results from the weakening of the muscles responsible for lifting the eyelids. This occurs when autoantibodies block acetylcholine receptor, preventing proper muscle contraction. The second is the diploma. It is known for a double vision due to the weakening of extraocular muscles. Patients often experience double vision. The intensity of these symptoms can vary throughout the day, making it a fluctuating challenge for those affected. Facial muscle weakness is a factor of the diploma. MG often leads to a reduction in facial muscle strength, resulting in a mask-like appearance, difficulty smiling, and challenges with facial expression. The fourth type of the symptoms of the myasthenia gravis is the dysphagia or the difficulty swallowing. Throat muscle weakness in MG patient can cause difficulty swallowing, leading to choking or aspiration. This can complicate eating and drinking, making these symptoms a significant concern. Next is the limb and neck weakness. Patient may experience weakness in the arms and legs, especially in the muscle closer to the body or the proximal muscle. Next is the respiratory muscle weakness. In severe cases, MG can weaken the muscle that control breathing, muscles that potentially leading to respiratory failure, a critical condition known as a myasthenic crisis. Fatigue is generalized fatigue is common, worsening as the day progresses or after physical exertion. This is due to the fluctuating nature of muscle weakness in MG. How is myasthenia gravis diagnosed? Blood tests. These tests look for antibodies that may be present in people with myasthenia gravis. Genetic tests. These tests are done to check for conditions that run in families. Nerve conduction study. A test called repetitive nerve stimulation is used to diagnose with myasthenia gravis. Electromyogram, a test that measures the electrical activity of a muscle. An EMG can detect abnormal electrical muscle activity due to disease and neuromuscular conditions. The characteristic symptoms is fatigable skeletal muscle weakness. Initial weakness often affects only ocular muscles, manifesting as ptosis or hanging of the eyelid, or diplomia, double vision. Other muscles that can be involved are bulbar muscles, which are necessary for speaking, leading to dysarthria, chewing and swallowing, causing dysphagia. Respiratory muscles can also be affected in up to 20% of cases with ACHR-MG, leading to a myasthenic crisis where patients need to be ventilated artificially.
The most serious complications of myasthenia gravis is myasthenia crisis. This is a condition of extreme muscle weakness, particularly of the diaphragm and chest muscles that support breathing. Breathing may become shallow or ineffective. The airway may become blocked because of weakened throat muscles and buildup of secretions. Myasthenia crisis may be caused by a lack of medicine or by other factors, such as respiratory infection, emotional stress, surgery, or some other type of stress. In severe crisis, a person may have to be placed on a ventilator to help with the breathing until muscle strength returns with treatment.
Myasthenia gravis is a chronic condition that can be managed with treatments like cholinesterase inhibitors, immunosuppressants, plasma exchange, and thymectomy surgery. Regular exercises, a balanced diet, and managing fatigue with rest are important lifestyle adjustments. Avoiding heat exposure is also crucial as it can worsen symptoms.